So today I'm going to talk on this interesting topic, which is the toxic toddler. 2 pills can kill. So first of all, I will go through, and then at the end, I'm doing a small quiz. So I hope this presentation will be interesting to all of you. So management of poisoning in toddlers is very challenging compared to management of poisoning in older children and adults due to several reasons. First of all, poisoning event in toddlers is often unwitnessed, and they ingest the poison often unintentionally. And therefore, to gather an accurate or reliable history is very difficult, and history is often vague. And for the same reason, the 2 important bits of information, which are the determination of the ingestion time and the ingested dose, is again very difficult when it comes to toddlers. And the circumstances of poisoning also are highly variable as a child grows from infancy towards teenage years. And also, compared to adults and grown-up children, the toxicokinetics of young children are different because of their smaller body weight, higher body surface area, and smaller age, so that the same dose can be quite toxic in the toddler compared to an older child or an adult. And also, certain ingestions may have serious safeguarding concerns, so we need to be extra vigilant apart from being mindful of the right medical management of children. And a few pills can kill them, especially infants and toddlers with certain poisons. That is the topic of today's presentation. Therefore, our risk assessment should be based on the worst case scenario when it comes to suspicious poisoning in toddlers. So when we look at the global epidemiology, the WHO report on the child injury prevention published in 2008 reported that pediatric pharmaceutical exposures and poisonings continue to rise significantly, causing morbidity and mortality in children. And the American Association of Poison Control Centers 2017 report identified at least 7 different classes of drugs which led to serious toxicity and death with even small ingestions in children. So why toddlers are at higher risk compared to older children and adults for serious complications for a given dose of the medication? Firstly, as the child ages, the total body water increases, which means the volume of distribution in which the drug gets distributed also increased. And this means that for a given dose, the concentration achieved in plasma is going to be higher in a toddler or infant compared to an older child, causing serious toxicity. And body surface area in children is higher compared to older children. Therefore, and this together with the fact that the skin being thinner compared to older children and adults, dermal absorption and the local, like toxicity of topical applications, going to be higher in infants and neonates compared to older children. And infants and toddlers have got small airways. Therefore, drugs such as propranolol or other drugs which act on the bronchial tree, causing bronchoconstriction, or the poisons which cause increased secretions, such as organophosphates that result in bronchuria. So the problems with these agents are also going to be quite intense compared to that seen in an adult or an young older child. And young children have greater minute volumes. This means the drugs which are inhaled are going to accumulate in higher concentration in lungs of smaller kids compared to grown-up kids. And children have a growing up kidneys and liver hepatobiliary system up to a certain time of their life. And if an insult happened during this period, so kidneys and liver are the organs mainly concerned with metabolism and elimination of poisons or drugs. So they can concentrate into higher levels during these stages of life. And also, during the breastfeeding, certain drugs can be secreted. For example, aspirin, as well as cocaine, like in drug addict mothers, and lithium in mothers with bipolar disorder. So these drugs, which can cause serious toxicity, can get accumulated in the baby through secretion via breast milk, although the child does not ingest the poison. So why children are more susceptible to poisoning? So we can see two peaks of poisoning as a child grows from infant towards a teenager. First peak is seen in the toddler years, and these group of children ingest mostly unintentionally at the home premises mostly, and they ingest minimally toxic doses most of the time because they do so accidentally and there is no intention of committing self-harm. And the incidence is largely determined by the availability of poisons within the environment, maybe within the home or outside home. And it occurs due to the exploratory inquisitive behavior of the child. And they all, of course, lack the sense of danger. So because of these reasons, they tend to experiment, or they tend to test with substances so that they also may accidentally ingest a poison leading to toxicity. Whereas in adolescents, they ingest a poison both intentionally as well as unintentionally. And that is the age group where the deliberate self-harm is more commonly seen. And also there is also a group of children or grown up like teenagers who tend to experiment with illicit substances and recreational drugs when they get together at school, sometimes at school or sometimes in peer groups. So two pills can kill. So what are these important pills that we need to know? And ingestion of 1 or 2 pills can actually kill an infant or a toddler. The first group of drugs are sodium channel blockers. And these include tricyclic antidepressants. And we use tricyclic antidepressants sometimes to use aneuretic disorder in children with imipramine. And beta blockers we use sometimes to treat hemangioma, sometimes we use propranolol as prophylaxis of migraine, sometimes we use these drugs to treat hypertension in children. And then antiarrhythmic drugs and chloroquine. Nowadays it's not frequently used, but it was used when we had malaria epidemics, and it's still being used by other countries as a travel precaution whenever they visit tropical countries. So all these drugs belong to sodium channel blocking family, which can cause a blockage of cardiac sodium channels and severe cardiac toxicity. And the next group of drugs is the calcium channel blockers, including verapamil and diltiazem. So they block the calcium channels, resulting again cardiac toxicity mainly. And then there are other important pills that we need to know. Opioids. So opioids, this can happen at 2 stages. Firstly, infants or neonates can get affected by an heroin abusing parent. And also sometimes in teenagers, they may experiment with opioids because it's a recreational drug. And then theophylline is widely used in our practice sometimes. And it has a very narrow toxic therapeutic window, and it can cause serious cardiac toxicity and CNS toxicity in overdose. And then amphetamines, which are sympathomimetic drugs, that can again cause severe cardiotoxicity, cardiac arrhythmia, and acute myocardial infarctions. And then we have sulfonylureas, including tolbutamide, glibenclamide, glipizide, which are used mostly by adults. So nowadays, most families, at least there is one family member who has type 2 diabetes. So these drugs are not uncommon in home premises. So if they are stored unsafely, a young child is likely to ingest one of these tablets. And then there are other like non-pill agents, but which have serious toxicity following ingestion of a very small quantity. And these include the topical preparations of salicylate, including the oil of wintergreen or methyl salicylate balm, And then toxic alcohols, methanol, ethylene glycol, which are used as vehicle coolants. And then organophosphate, which is still common in rural Sri Lanka, which is still the most common pesticide poison consumed both by adults and children. And then oleander, again a serious poison, which is still common, and it's the most common plant poison to be ingested by children from rural Sri Lanka. And then camphor, which sometimes is contained in mothballs and in camphor oil, can also have serious effects in small quantities. So if you look at the gravity of this problem, the child mortality related to pharmaceutical ingestions, Safe Kids Worldwide, which is an NGO based in USA concerned with prevention of accident-related childhood mortality, reported that every 12 days, a toddler dies from medicine poisoning. This is in USA. And then another paper published in Archives in 2016 reported findings from an island-wide survey in United Kingdom, reported that there had been at least 128 deaths due to pharmaceutical poisonings over a period of 13 years from 2000 to 2030. And they reported that the most common pharmaceutical agent that caused mortality in children was methadone. Methadone is still, we also use methadone, so that is used as a treatment method to people who abuse heroin. So it's quite commonly used by people who addict heroin. And this is followed by benzodiazepines. So these two agents were the most common agents associated with mortality reported in the United Kingdom. And then another paper from USA, which was published very recently last year, accumulated the data from the 2019 annual report of the American Association of Poison Control Centers, National Poisoning Data System. And they reported their common agents which cause childhood mortality as diphenhydramine, which is an anticholinergic agent, and opioids, mainly methadone and opioid class drugs, and amphetamines, and related sympathomimetic drugs, and paracetamol, and benzodiazepines as the most common drugs implicated in deaths of children following ingestion of pharmaceutical poisons. And then a survey of infants and toddlers mortality, again in the same setting, United States, published in 2011. They reported when it comes to toddlers, the most common agents as cardiac drugs, like we discussed, beta blockers, calcium channel blockers, digoxin, and then psychotropic agents, and recreational drugs like cocaine, methamphetamine, and alcohol, and analgesics as the most common agents ingested by toddlers accidentally. And in 14% of the time, these toddlers had ingested more than one agent, and that resulted in mortality. And this paper was published subsequently in 2017 in the Pediatric Annals. When it comes to the Sri Lankan context, so our statistics show that mortality rate attributed to unintentional poisoning in Sri Lankan populations, so unintentional poisoning mainly concerned with children, so that was initially 0.6 per 100,000, and it has dropped to 0.4 per 100,000 from 2010. However, there is a tendency that we may miss data because of the significant underreporting and lack of quality studies conducted over the period of past 20 years. So individual pediatric mortality rate data are largely underreported at national level. However, the studies have reported rising trends for poisoning with pharmaceutical agents. And also, this paper published in Emergency Medicine International reported that severe toxicity had been observed with certain agents such as methyl salicylate, tramadol, and related opiates, and beta blockers in some children. However, no mortality was reported in this prospective study. So I would like to go through briefly about what these agents are and then what their mechanism of action and what the clinical features, and then how we can manage based on up-to-date evidence, so that if we come across this one of these children with similar poisoning, then we can be a bit extra careful compared to other types of poisons. So firstly, beta blockers. So beta blockers are one of the dangerous types of poisons with a narrow toxic therapeutic ratio as well as serious side effects. So beta blockers act by blockade of beta receptors present within the cardiac myocardium as well as myocardial conduction system. So that leads to direct myocardial depression as well as impaired myocardial conduction. So the result is severe bradycardia and intractable hypertension. And the worry about this is like the children, like, you know, an infant may present with just ingestion of couple of adult tablets and may not show any warning signs, for example, compensated shock or features of any compensated stages, and then all of a sudden can decompensate with intractable hypertension, which may be refractory to fluids and inotropes. And the other thing is, now we have different types of beta blockers because of the concerns about safety. Now there are many beta blockers with cardioselectivity. For example, carvedilol and atenolol, which has less like a narrow toxicity range compared to propranolol, which also can have CNS toxicity. However, it's important to recognize that this cardioselectivity is lost in overdose of any beta blocker overdose. And agents like propranolol, sotalol are considered more toxic compared to atenolol and other agents because they are more cardiotoxic as well as they are lipophilic. Lipophilic means they will cross the blood-brain barrier, result in seizures and coma as well in significant overdose. And the children who overdose beta blockers can die of intractable hypertension with extreme bradycardia and asystole. And their hypertension can be refractory to fluids and inotropes initially. And deterioration can occur rapidly and without any warning sign. And so if a child, goes into hemodynamic instability, one of the first things to do is to protect the airway by elective intubation and ventilation. However, this intubation can cause vagal response and can result in cardiac arrest. So it's very important that before procedures such as gastric lavage or intubation, we need to pre-treat with atropine like all children with beta blockers. And so when it comes to investigation, so all children warrant ECG and continuous cardiac monitoring because there are major toxicities related to heart. And what is more important to monitor is the QRS interval. So presence of a QRS interval of more than 100 milliseconds is predictive of seizures and CNS toxicity, as well as overall serious toxicity. And beta blockers can cause electrolyte abnormalities, including hypokalemias and severe metabolic acidosis due to intractable shock and hypoglycemia in propranolol overdose. So monitoring of these parameters is very important when we manage a child with beta blocker overdose. So what is the treatment? So a child with hemodynamic compromise need to be treated with vigorous fluid resuscitation. However, most of these children are resistant to vigorous fluid resuscitation and may need other treatments as well. So IV calcium is a direct inotropic agent, so which can be used either as IV calgluconate or calcium chloride as a bridging agent to maintain blood pressure and heart rate until we treat with other more definitive treatments. And any child with deterioration or impaired consciousness, whether or not they have normal blood sugar, need to be treated with IV dextrose bolus, because although their blood sugar concentrations are normal, their CNS sugar concentrations are likely to be low, and that's one reason why they develop impairment of consciousness. So all children with impaired consciousness irrespective of normal blood sugar, need to be treated with IV dextrose bolus. And activated charcoal can be given, but it's very important to be mindful that these children will go into coma, and that means airway compromise. Therefore, securing of airway is very important before administration of activated charcoal to a child who is drowsy. And then atropine is used as bridging agent until we use other agents such as isoprenaline or adrenaline to get the heart rate up. And the inotrope of choice for beta blockers is insulin plus dextrose. So insulin here acts as an inotrope, and that also make the blood sugars like sugar more available to the heart to use. Although the heart predominantly uses ketone bodies at physiological conditions, in stressed out heart, the main energy source is glucose. So giving dextrose plus insulin and maintaining blood sugar levels within normal to high levels within the plasma concentration makes it easier for the heart to grab energy substrates to functioning smoothly. And then some of these children may need cardiac pacing for bradyarrhythmias. And in the ideal setups, severe beta blocker overdose children are treated with extracorporeal membrane oxygenation. So this can buy time until the toxins get washed off, metabolized, and excreted from the circulation. Children can live on the machine. And so compared to other conditions, the good thing about poisoning is that after some time, all the poisons get metabolized and eliminated and excreted from the body. So if we can manage the time well until the drug is eliminated, this means the prognosis is going to be good. So thereby, extracorporeal support has a vital role in managing children with severe poisoning, severely poisoned children. And the next drug I want to talk is the chloroquine. So chloroquine is one of the deadliest drugs to toddlers. So the toxic dose is considered 10 milligram per kilo, and the mortality has been reported in doses as low as more than 30 milligram per kilo. And one tablet is about 155 milligrams, so ingestion of 2 tablets means more than 300 milligrams, so which can be very well above this mortality, like lethal dose of 30 milligram per kilo. And what it does, like how it brings on the toxicity, is through blockade of sodium channels. So even like compared to beta blockers, chloroquine has a very fast action. So it results in very fast toxicity, leading to depression of the cardiovascular system and the central nervous system. And also it causes, because of the inhibition of the intracellular potassium shifts, severe hypokalemia. So sometimes a child can die within a couple of hours if had ingested a couple of tablets by a child weighing less than 5 to 10 kilograms. So if we look at the clinical features, the main clinical features are related to sodium channel blockage in the cardiovascular system. Similar to beta blockers, it causes intractable bradycardia, cardiogenic shock, as well as ventricular arrhythmias. And there can be QRS and QT prolongations. And in the neurological system, that leads to coma and confusion and suppression of the breathing center in the brainstem, resulting in respiratory depression. And also it causes seizures. And metabolic effects include hypokalemia, hypoglycemia, and also sometimes it can cause liver and kidney toxicity in overdose. And because of this very, very fast action, activated charcoal is not very helpful. And the effects are in kind of more or less the same, although they are fast in chloroquine poisoning. So these children are likely to present in shock if they had ingested a very toxic dose. So we have to concentrate on vigorous fluid resuscitation and correction of severe metabolic acidosis. So plus or minus using adrenaline. And most of the children are going to be drowsy, so their airways are at risk. Therefore, attention should be given to early securing of the airway with intubation and ventilation. And the antidote we use in chloroquine, because their main action is sodium channel blockade, is IV sodium bicarbonate. And the therapeutic targets are to maintain a blood pH towards alkalemic side with a pH of 7.5 to 7.55. And because they are neurotoxic, seizures are treated along the standard lines with benzodiazepines. And also because of the blockage of potassium channels, they can have significant hyperkalemia, which can be treated with potassium chloride. And then similar to children with beta blockers, chloroquine, because of its fast action, but duration of action is more prolonged. However, because of the reversibility, there is of course a place for extracorporeal membrane oxygenation in managing severely toxic children. And let's look at the calcium channel blockers. So they share some of the features of beta blockers, as we all know, and they are used mainly by adults in households who have hypertension. And the action of calcium channel blockers are to inhibit the L-type cardiac calcium channels, as well as those in the vascular smooth muscle. So a blockage of cardiac calcium channels result in one way, uncoupling of the contraction, resulting in decreased inotropy, as well as because of the blockage of conduction through SA and AV nodes, that results in decreased chronotropy. So that can result in intractable hypertension and severe bradyarrhythmias. And because of the inhibition on the calcium channels present in the vascular smooth muscle, toxicity can result in significant vasodilatation and vasodilatory hypertension. And also there are calcium receptors present in the pancreas, which are concerned with release of insulin. So blockage of these receptors result in impaired release of insulin, result in hyperglycemia. However, hyperglycemia is not a threat to children. It just helps you to diagnose. Like in cases, if child presents with hypertension, bradycardia, but like I said, there is no clear history of ingestion, and you don't know whether it's calcium channel blockers or beta blockers. But if there is hyperglycemia present, then you can easily suspect the possibility of calcium channel blocker overdose over an overdose of beta blockers. So that just helps in early diagnosis and doing a more accurate risk assessment rather than implying or predicting prognosis. And similar to beta blockers and chloroquine, the death in calcium channel blockers is also caused by intractable hypotension and asystole. And the investigations, again, they cause the same metabolic as well as cardiac complications similar to beta blockers. So it's important that we do an ECG in any child with hemodynamic compromise and arrange continuous cardiac monitoring. And then blood sugar needs testing. We are likely to see an hyperglycemia, especially if the child has ingested agents such as nifedipine. And then monitor electrolytes. They can have hyperkalemia and monitor blood gases because they can have intractable acidosis. And there is a place for GI decontamination, activated charcoal in children with calcium channel blockers, because in overdose, calcium channel blockers inhibits the gut, prolongs the gut transit time, and that can prolong the drug absorption from the GI tract, which means there is a fraction of the drug which can be absorbed to activated charcoal within the GI tract. And then intractable hypertension should initially be managed with fluid resuscitation, plus or minus vasopressors or adrenaline. And the choice of inotropes depend on whether the child is having a vasodilatory hypotension or a cardiac-related cardiogenic hypotension. Like I said, because if the predominant effect is on the vascular smooth muscle, then your choice should be to use vasopressors. Whereas if it's due to predominant myocardial depression, then adrenaline should be our choice of inotrope. And to verify whether the child is having vasodilatory or vasodilatory or cardiogenic hypertension, what can be done is a point of care ultrasound scan as well as a bedside 2D echo. And then this calcium channel blockers, the antidote we use is IV calcium, which competes with the calcium channel blockers to act on the receptors and thereby overcoming the blockage. And severe bradyarrhythmias can be treated initially with atropine and can be followed by chronotropic agents such as isoprenaline as well as cardiac pacing. And the inotrope of choice for calcium channel blockers is again high-dose insulin euglycemia therapy, that is insulin combined with dextrose, and here insulin acts as a cardiac inotrope. And then similar to beta blocker overdose, chloroquine overdose, these effects, although life-threatening, going to be temporary. So if we can survive the child during the period of serious toxicity using ECMO, there is a chance that we can save the life of the child. And the next class of drugs is the sulfonylurea, which is again very commonly used in our household because most parents or most grandparents are diagnosed with type 2 diabetes. So sulfonylureas, compared to metformin, which usually does not cause hypoglycemia and overdose, sulfonylureas cause profound hypoglycemia following ingestion of as little as 1 or 2 tablets in small children. And that also can lead to unregulated insulin release, resulting in erratic drops in blood sugar concentrations. And also, this can result in delayed hypoglycemia. So this requires for us to monitor longer than usual. We usually monitor children for like 4 hours, but sulfonylurea-induced hypoglycemia can be brought on several hours after, like perhaps after 8 hours. So this study published in Journal of Pediatrics, they recruited about 185 children exposed to sulfonylurea agent, and they reported that 96% of those who developed hypoglycemia did so within 8 hours. And there was a fraction of children who developed symptoms of hypoglycemia later than 4 hours. So it's very important that we monitor longer than usual the old children who comes with a clear history of ingestion of sulfonylureas. So the minimum observation time is 8 to 12 hours, and this should be supplemented with frequent blood sugar monitoring. And if there is a tendency to have low blood sugar, that should be treated with IV dextrose boluses. But if we have to give more than 10% dextrose boluses, or we need to give several dextrose boluses, it's high time to consider giving IV octreotide infusions, considering it as intractable hypoglycemia. So this the management pathway shows the same approach. And the next class of drugs are the opioids. So we use agents such as tramadol in surgical wards, even to children, as post-operative pain relief. That's used quite commonly. And also heroin is an important opioid, which sometimes is abused by certain mothers, street mothers. So there are babies or even the toddlers can experiment with them, so they can get accidentally or indirectly poisoned. So that's one of the serious toxins which can be seen in children. And also there are like certain preparations such as codeine and certain medications used for chronic painful conditions. So these children also likely to get overdose or abuse these agents. And the opioid toxidrome presents characteristically with 3 cardinal features. One is the respiratory depression, and the other is the central nervous depression, that is impaired consciousness and coma. And the other one is the pinpoint pupil. So if we see these 3 clinical features together, there should be a strong suspicion towards overdose of opioids. And in addition to that, the overdose child may present with a cold, as presented in the diagram, may present with a clammy and pale skin because of the poor respiration and hypoxia, and blue lips or blue skin, and slow heartbeats and slowed respiration. And a recent article published in CNN News reported that opioids were killing more than 9,000 children from the period from 1999 to 2016, causing highest number of mortality following a pharmaceutical agent, according to their report. And this is the USA-based National Vital Statistics reports published in cdc.gov reported the frequency of drug types concerned or considered with infant mortality. There are, as you can appreciate, methamphetamine, which is a recreational drug, topped the list. And then after that, what you get is the opioid drugs. And then other drugs include cocaine, cannabis, like other recreational drugs. And then lower down, they had observed benzodiazepines as well. And the above article published in Addiction, assessing the relationship between maternal opiate use and neonatal mortality. That study was based on the heroin-abusing mothers during pregnancy and the outcome of neonates. And they reported, these pregnant mothers are going to be various control programs, like addiction control programs. What we give for addiction control is methadone. And methadone, as I said, it's one of the very likely, most likely agents for poisoning and related deaths in children. However, their conclusion was that, as far as you comply with methadone treatment and heroin use, the outcome was worse in those who were not taking methadone and who were still abusing heroin compared to those who were on good control of heroin use while on methadone. So that's an interesting article to read. So when it comes to management of opioids, the management of opioids is supportive. So the danger of opioids is that can lead to acute respiratory depression. And if we don't apply airway securing, airway stabilization, these children can die of hypoxia. So the main mode of treatment is supportive. We may have to give breathing support. We may have to maintain the oxygenation. And sometimes, if we are sure that the child has ingested opioid toxin, we can trial a dose of naloxone, and after which a child will soon recover if there is no underlying hypoxic brain damage caused due to opioid overdose. And there is a place for activated charcoal as well, with sustained release opioids. However, it is very important that we secure airway, as most of the children are going to have a depressed airway, depressed respiration, as well as depressed sensorium due to opioid overdose. And sometimes naloxone infusions are occasionally needed for children or for neonates who are accidentally given sustained release preparations of opioids or heroin. And the other class of drugs which can cause death in children is alpha agonist or Clonidine. Now, Clonidine in pediatric practice we use to treat children with attention deficit hyperactivity disorder, as well as some children with tics, and also to treat some forms of migraine. And similar to beta blockers and calcium channel blockers, the Clonidine, because of this alpha adrenoceptor agonist properties, so what it actually does is it inhibits the central sympathomimetic reflex. So inhibition of sympathomimetic reflex lead to intractable hypertension and bradycardia. And also because of the direct CNS toxicity that results in CNS and respiratory depression. So these children again can die of intractable hypertension and that result in death. Because of their rapid onset of action, decontamination is generally not indicated. In fact, it's contraindicated. And the main treatment is concerned with provision of timely supportive care. And salicylate, commonly known as oil of wintergreen or methyl salicylate balm or aspirin, can have serious effects. But what we are mostly concerned is the topical preparations, which is the methyl salicylate balm, which is about 5 times more potent than oral salicylate. And salicylate can get easily absorbed through immature skin, especially in neonates and young infants. So how it exerts toxicity is through uncoupling of oxidative phosphorylation, which governs cellular functions all around the body, and thereby it inhibits Krebs cycle and increases lactate production. So there will be widespread activation of anaerobic metabolism, increased metabolic acidosis, as well as severe hypoxia. And also, because of this initial hypoxia as well as direct effects of salicylate stimulates respiratory center that can cause hyperventilation and respiratory alkalosis. And in overdose, once ingested in oral route, it can cause formation of stomach concretions, like salicylate concretions, can cause significant delay in gastric emptying with prolonged absorption and increases in volume of distribution, adding to enhanced toxicity. Because of this delayed toxicity, gastric lavage has a place. We hardly use gastric lavage nowadays because of the unfavorable risk-benefit ratio. However, in salicylate poisoning, because of the delayed toxicity, gastric lavage can be undertaken up to 4 hours post-ingestion. And also similarly, there's a place for multiple dose activated charcoal, especially for children who have ingested sustained release preparations. And in places where salicylate measurements are available, they can be used effectively to monitor the child as well as to guide treatment. And similar to beta blocker poisoning, salicylate also accumulate in the central nervous system because of its higher volume of distribution. Therefore, it can cause seizures. So whether or not your blood sugar concentration is normal, it warrants treatment with IV 10% dextrose boluses to children with seizures. And the 2 main methods of treatment of salicylate toxicity are urine alkalization and hemodialysis. This is given on the basis that salicylate is excreted mainly through kidneys, and salicylate is a dialysable drug compared to most other pharmaceutical poisons. And yellow oleander, so when it comes to our setting, so it contains digoxin. The toxin is tervertin A, which actually has compounds similar to what we see in digoxin tablets. So it's one of the major public health issue in our rural part of Sri Lanka. And compared to digoxin, the management of yellow oleander poisoning is complicated because the absorption is often erratic. And compared to digoxin, it is very difficult to predict the release of the drug from the yellow oleander seeds. And also there are no specific diagnostic tests, and given that delay to presentation and availability of expensive, like lack of availability of treatment as well as availability of very expensive treatment, the management of yellow oleander poisoning is often complicated. And its poisoning is mainly related to cardiotoxicity, as it inhibits the cardiac channel called sodium-potassium ATPase. And due to blockade of this channel, that results in impaired movement of potassium into the cardiac cells, resulting in hyperkalemia. So in addition to cardiac toxicity, bradyarrhythmias and heart blocks, you will see hyperkalemia as well as a sign of toxicity. And death usually occurs due to asystolic arrest. And this ECG shows a child with complete heart block following oleander poisoning. And when it comes to monitoring of children with yellow oleander or digoxin poisoning, continuous cardiac monitoring is warranted up to 72 hours. So these children should never be discharged early, because especially oleander poisoning, they can have very delayed onset toxicity. And electrolytes need monitoring because they can cause severe hyperkalemia, and also they can have hypokalemia, and hypokalemia indicates a worse prognosis. And if facilities available, our country does not have these facilities, but if it's available, that helps in guiding administration of antidotes. And the treatment, because if its toxicity lasts longer and absorption is quite erratic and prolonged, there is a place for multiple dose activated charcoal, especially to children who ingest yellow oleander. And then we also should need to concentrate on treatment of hyperkalemia. However, here we need to avoid calcium. We normally use calcium to treat very high levels of hyperkalemia, but if you use calcium in yellow oleander poisoning, because their intracardiac calcium concentrations are already high due to the blockage of sodium potassium ATPase, if you give more and more calcium to these children, that can lead to a condition called stone heart. So the heart remained in tetany, that can lead to fatal cardiac arrhythmias. So calcium should be avoided and contraindicated in treatment of hyperkalemia of children with yellow oleander poisoning. And then bradyarrhythmias can be treated with atropine as a bridging treatment, and then we can use other agents such as isoprelline or cardiac pacing to children with more prolonged bradyarrhythmias. And the antidote concerned with yellow oleander is antidecoxing tab. However, it's not readily available, as well as it's quite expensive. And then, although not a pill, ethylene glycol, which is used in vehicle coolants, is a serious poison. Hello? It's a serious poison. So that can result in formation of inorganic acids that results in severe metabolic acidosis with a inexpressible or unexplained high anion gap. And here, because they are toxic alcohols, activated charcoal is contraindicated. And there are two antidotes available to treat ethylene glycol poisoning in addition to supportive treatment, and they include ethanol and fumeprazole. And then I think the last pill I want to talk to you about is the tricyclic antidepressants. So it is again a sodium channel blocker. It inhibits fast sodium channels in the brain and myocardium, and also it has multiple other receptor effects, including blockage of muscarinic and alpha-adrenergic receptors. So blockage of sodium channels results in, similar to beta blockers, cardiac toxicity manifesting as intractable hypertension or severe bradyarrhythmias. And this blockage of muscarinic receptors can result in anticholinergic toxidrome. And blockage of alpha-adrenergic receptors can result in severe vasogenic hypotension. So because of this blockage of alpha-adrenergic hypotension, like best choice of treating hypertension related to TCA overdose is something which has vasopressor effects. So we prefer noradrenaline compared to adrenaline and other inotropes in treating hypertension of children with tricyclic antidepressants. And so it is very important that we monitor the ECG and continuous cardiac monitor because of the blockage of sodium channels that can cause prolongation of the QRS interval. Similar to beta blocker poisoning, the prolonged QRS interval is protective of the risk of overall outcomes, including the prognosis. So it's very important that we monitor the QRS interval in continuous cardiac monitoring. And when it comes to treatment, so because it inhibits or bring on toxicity by inhibition of sodium channels, we can deploy plasma alkalization using IV sodium bicarbonate, and it's used as an antidote. And this alkalization we can facilitate by hyperventilation of the child as well, to ensure that the drug is washed off from the circulation. So alkalization helps dissociation of tricyclic antidepressants, as well as sodium displaces tricyclic antidepressants from the sodium channels. And volume expansion is important. So these children need to be treated with volume resuscitation and inotropes, preferentially with noradrenaline. And glucagon also can be used for its inotropic effects. So these are the main the important pills that we need to know, and the pills that can bring on mortality in very young children following ingestion of a dose as low as 1 or 2 tablets. And in managing, so there are some important pitfalls that we need to recognize and correct. So there is a common saying that that we tend to judge children by looking at them. But they looked so good. But this doesn't apply to children with ingestion of these pills. They may look very good, but in the next minute they can deteriorate. So this is not correct when it comes to management of children with poisoning following ingestion of these pills. And the other is it was a herbal product, and the herbals are natural and safe, but it's again not true. Herbal products can be quite detrimental in some occasions. And then sometimes we say we monitor all overdoses for 4 hours, but it's not so. There are certain poisons such as calcium channel blockers, oleander, and sulfonylureas, where we need to, even though the child is completely asymptomatic, we will have to monitor the child for a longer period if we are sure the child has ingested these poisons. And then judging the patients based on oxygen saturation is again incorrect. What we want to have is the respiratory drive. Sometimes child will have good drive in respiration. For example, following opiate ingestions, child will have saturations of 98%, but with deterioration of the respiratory drive, the saturations will soon start dropping. So having a normal saturation is not reassuring at all. And then we do not need to X-ray to confirm the position of the NG tube. Just push the charcoal. So we tend to do this in the emergency departments, but we should perform X-ray to confirm the position of the NG tube before administration of any charcoal. Because if we do not, there is a chance that the charcoal can go into the respiratory tract, and that can lead to more harm than the poison. Yeah, so that's something we need to keep in mind when managing children with activated charcoal. And then other thing is they are not moving, so they are not seizing. So judging based on the presence or absence of jerky movements is not predictive of seizures at all. Sometimes children can have electrical seizures, but no clinical seizures. So it's very important to suspect seizures. And these children need to have appropriate evaluation and treatment, even if they are not manifesting seizures. So this is what we do for every child with serious poisoning. So you have this mnemonic RRSI-DEAD, so which stands for resuscitation, risk assessment, supportive care, investigation, decontamination, enhanced elimination, antidotes, and disposition. So this stands for management of any poisoning, and this applies to management of these pills as well. So resuscitation is done through standard approach of A, B, C, D, E. So airway needs careful assessment, especially when children ingest agents such as CNS depressants and cholinergic agents such as organophosphates and corrosives. And breathing needs attention, again with agents such as CNS depressants like benzodiazepines, opiates, and then cholinergic agents, and following aspiration. And then circulation needs attention with ingestion of agents such as beta blockers and calcium channel blockers. And then seizure control, management of hypoglycemia, correct hypothermia. So hypothermia can be a problem with certain poisons. And then resuscitation and antidotes. Sometimes antidotes need to be administered on the resuscitation table itself. For example, naloxone in opioid overdose. So the key practice points I want to highlight. So like I said, it's very vague, and the history is often unreliable. So we had to rely on what is available in managing children with poisoning, toddlers with poisoning. So we have to do a risk assessment which is as accurate as possible, and that is helpful in timely management of children. And then we should put in an effort to identify the toxidrome, that is the cluster of clinical features, which can potentially cause the clinical presentation. So that will help us narrow down the differential diagnosis and treat early. And while keeping poisonous conditions like poisoning conditions in mind, sometimes the unconscious child presents with something else, like for example meningoencephalitis, severe sepsis, and so on. So we have to be mindful of other relevant medical differential diagnosis as well, managing the sick child coming on with a history of suspicious poisoning. And always, if child presents with clear history of ingestion or a serious ingestion like one of these pills, we always need to manage as for the worst case scenario, however well the child is currently. And also sometimes we may miss the safeguarding. Some children may have safeguarding concerns. Sometimes the children can be administered the poison by a responsible caregiver, in which the history can be vague. History is not incompatible with the presenting symptoms and signs. So we also need to be mindful about these scenarios as well, and then bring them to the attention of the people who are concerned with ensuring safeguarding of children. So I have created a small quiz, and I will invite you to try answering. There are like 4 questions altogether. So first one is a true or false stem. First is the NG tube position needs confirmation with X-ray in all children undergoing decontamination with activated charcoal. Anybody would like to answer? So that answer is yes. So we should do X-ray in all children undergoing decontamination through NG tube. And then all asymptomatic children with poisoning can be discharged after 4 hours of normal observations. Anybody can type in answers in the box? Yes, so this is false. All symptomatic children can't be. Like, there are exceptions like calcium channel blockers, sulfonylurea, oleander, who needs a prolonged observation period. And opioid toxicity lead to dilated pupils. Yes, that's false. So opioid toxicity lead to pinpoint pupils. And intubation should be considered even if oxygen saturation is 100% in serious poisonings. True or false? Yes, true. So this may be true, though this is not always true, but this can be true. For instance, like children who have been poisoned with CNS depressant drugs, although they have 100% saturations, but in severe poisoning, we need to consider protecting airway to prevent aspiration, to administer to activated charcoal, as well as to ensure the airway is not blocked. Forceful administration of activated charcoal is better than giving it mixed with a soft drink. Yes, that's false. So we don't recommend forceful administration of activated charcoal. What we believe is like administration of forceful activated charcoal forceful is more harmful than not administering it. However, an easier way of administering activated charcoal, because it's not palatable, children don't like to eat it, drink it, because of this it's not palatable and it's bitter taste. So you can of course mix it with a soft drink or a ice cream or a yogurt, so that children can easily eat it. And the next question, this is a best of 5 question. Which of the following is the best inotrope for calcium channel blocker poisoning? Vasopressin, adrenaline, high dose euglycemia treatment, dobutamine, dopamine. So I can see answer A. Yes, C. So yes, C is the answer. So for agents such as beta blockers and calcium channel blockers, because there are calcium receptors in the pancreas as well, and the myocardium uses glucose in favor of ketone bodies in stressful conditions, insulin glycemia therapy is considered the best inotrope in managing the refractory shock. And the next one, another best of 5 question. Which of the following is the best inotrope for TCA poisoning? Anybody wants to try? Which of the following is the best inotrope for TCA poisoning? Yes, it's A. It's A. So tricyclic antidepressants have alpha antagonist properties. So it leads to vasodilatation. So that's the main mechanism through which the hypertension is brought on. So noradrenaline is the choice of the inotrope in TCA poisoning. And this is a true or false question. Which of the following drug overdose needs observation longer than 4 hours in asymptomatic children? So you can just type in the letters, the correct answers. We have salicylate, glipizide, verapamil, diazepam, and atenolol. So the answers are B and C. B and C. So glipizide and verapamil, they can have a prolonged and unpredictable absorption in overdose and warrant observation for longer than 4 hours, even if they are asymptomatic. But others, if they are asymptomatic, completely asymptomatic at 4 hours, we can judge, or we can, calculate that they are kind of out of the danger zone. And the last multiple choice question, which of the following drug overdose result in sodium channel blockade? You can again type in the letters, correct answers, the related letters: propranolol, chloroquine, imipramine, tolbutamide, digoxin. So yes, A is correct. So A is, propranolol is a beta blocker. Any more answers? Yes, so chloroquine is the other answer, which causes sodium channel blockage, and then tricyclic. So imipramine is a tricyclic antidepressant, again leads to sodium channel blockage. So A, B, C are the correct answers. Tolbutamide is a sulfonylurea drug, so which inhibits insulin, which stimulates insulin release from the pancreas, and digoxin is an inhibitor of sodium potassium ATPase in the cardiac. So A, B, C are the correct answers. So thank you very much.